corner. Join in, put your questions, your thoughts in the chat. Feel free to raise your hand. If we have time, we'll try to get to you. Participate in the polls. Make this jam as fun as you'd like. But we're going to have a good time and learn over the next hour. All right, and don't forget that ASL feature. That is going to be your bottom right corner of your Zoom. You can select more, and sign language interpretation is available. That will pop up in your corner. But if you don't want it in that corner, I just learned that you can move that speaker, that interpreter, anywhere you'd like on your screen. That makes it best for you. And over the course of 5 seasons or 5 years of the Crisis Jam, we've had 561 unique speakers. So if you have a topic that you'd like to share, if you'd like to come onto the jam and do a future presentation, work with Stephanie Hepburn for a Crisis Talk article, we want to make sure we get you spotlighted. We have 3 individuals who are on their first Crisis Jam. So that's Dr. Barksdale, Gwenda Summers, Jim Westcott, who are highlighted there in yellow. Add it to the list. Let's make sure we get your name up there because you have something to share. And of course, you can find all the information about the Crisis Jam live stream on the website talk.crisisnow.com. You'll see the learning community. That is what this jam is. And in addition to that, you can register for the jam. We've got the cool backgrounds that all the cool kids have for 988. You can download that. You can watch old jams and make sure that you sign up for the jam because you do need a unique login. We've got some highlights here for you, past episodes, learning corners, tech corners, federal, state updates, anything that you need of like, hey, I remember that they talked about it on the jam. They catalog it here, the great team. So you should be able to find it. Again, that's talk.crisisnow.com. And then, of course, if you're joining us from YouTube, this is live stream, but you can also check out old episodes if you have a full hour to go back and want to see what the conversation was. These are also, again, color-coded, so shout out to the team, so that you can go to see other debates, fireside chats. Make sure you like and subscribe so that you do not miss an episode. Okay, and then our most recent live in location, which was just a few weeks ago in Columbus, Ohio. That live stream with Eric Hipple, Erica Clark-Jones, Jonathan Thomas, Alicia Best in Columbus, Ohio, and shout out to Doug Jackson, the 988 administrator, and the entire Ohio team. That was our most watched episode. So there was a call to say, hey, we need to make this the #1 episode, and you all answered. 15,000 views. Incredible, a testament to this community. Bravo, bravo, kudos. And if you missed it, it's available online, both at the talk.crisisnow.com or on YouTube. So as we continue our debates, we are in season 5. We have a debate today. Just want to notate that, again, we have Dr. Vernon Barksdale, who will be arguing that crisis facilities should not require parents to stay during a crisis episode. And we've got Gwenda Summers, who will be notating the affirmative that they should require parents to stay, much like you would for a physical emergency. So we had a little bit of a preview of that in the pre-show. So make sure you stick around because that is going to be pretty amazing. So for every debate, we do a survey to see where do folks stand. So make sure that you participate in this so we can see how effective our debaters are. Again, the beauty of these debates is that everyone wins because, you get to see different perspectives that you may not have gotten. So just make sure you take time to complete that poll so we can see, was the audience swayed one way or another? But on the horizon, next month, July 23rd, we'll have David Covington and Dr. Jessica Pollard debating coordinating follow-up services and crisis care. Does it require high-tech software solutions, right? So David is going to argue yes. Dr. Pollard is going to say, you know what? Low tech works just as fine. So stay tuned because there's been a lot of conversation. We even had a debate on AI. And so, do we really need high tech software solutions or can this be done in a low tech manner, right? Are we making it too complicated? I'm looking forward to that debate. And then in August, on the 27th, there will be Should States Prioritize Building Capacity in the Three Core Crisis Services? So, again, the crisis contact centers, mobile crisis teams, and crisis stabilization. We've got Paul Galdis, who will be arguing the affirmative that they should. And we've got Dr. Joe Parks from National Council who's saying, you know, maybe we can focus on one or two, but we don't need to do all three right now. So, again, very interesting topics. If you guys have topic ideas, presentation ideas, if you want to be in a debate, let us know. Be sure to reach out. We want to see and hear from you all. So, turning it to the news, if folks haven't seen, there was a journal article that came out from Dr. Pirtle and others on where the 988 Suicide and Crisis Lifeline is most used. And so some of the studies or some of the conclusions that they drew or noted was that areas and states where there were less promotion, less awareness of the line correlated with less utilization of the 988 line. And states where there was maybe more investment in their crisis services in the 988 crisis contact centers and their states saw increased utilization. So very fascinating article. Have worked with Dr. Pirtle on state appropriations. So just always interested in the work that he does. And then another good friend of the Jam, Set Free Indeed, which is led by Tanja Miles, has released their 2025 impact report. So if folks don't know Tanja and Set Free Indeed, make sure you check her out because she is phenomenal, amazing. And the work they do in Louisiana and across the country is just phenomenal with their in community teams, the Narcan distribution, making sure that folks get hope and help, as she likes to say. So make sure you check out that report and continue to watch the work that they're doing. So important. And as we mentioned at the top, making sure that we are reaching youth, young adults, teens, kids, where they are, getting them essential information, the correct information, not the misinformation that may exist. NAMI has released a report that is linked in the chat to help normalize conversations, get rid of stigma that still may exist, and show the next generation that they are not alone. And again, hopefully it gets better with each generation. They do it a little right. I have so much hope for Gen Alpha uh, because they got it. From my opinion, all the things that I learned as millennial that took me a lot of time to learn, they know right away and how to take care of their mental health. But we still have to make sure we are supporting them. So make sure you check out that report. Which leads us into our Crisis Jam showdown. So this question is going to be open for everyone, unless there's someone who would like to raise their hand and be on the hot seat for this showdown. But we're going to open it to everyone. Which of the following is not a key reason why early intervention in youth mental health is considered crucial? So make sure you read that question closely. Which is not a key reason? Is it mental health disorders begin in adolescence? Or early treatment can reduce severity and long-term impact? Youth are more responsive to medication, or it helps improves outcomes and social and academic outcomes. So let's see. Feel free to also put into the chat what you think the answer may be. And again, which one is not a key reason? So that might trip you up. But I have faith in this jam. All the jammers are super smart. And let's see, do we have an answer from the poll? Okay, here we go. It looks like 85% of folks are saying a reason that is not why early intervention is considered crucial is because youth are more responsive to medication. Okay. 6% of folks saying A, but you guys got it. I knew you would. 85% of this jam. Uh, so while youth mental health, while youth may respond well, effectiveness varies and isn't tied to age or medication responsiveness. So well done, guys. We tried to trick you with the not, but you saw right through it. Okay, so with that, we're going to move on, and I'm going to turn it over to another friend of the Crisis Jam, Dr. Deborah Piles, to moderate and introduce our debate.
Hello, welcome everybody. I'm really excited to be here to be hosting or moderating this fantastic debate, which came about through some real world conversations that we were having in Michigan and elsewhere, and looking to colleagues around the country. We have this debate on crisis facilities should require parents to stay during a crisis episode. The whole issue on requirement is an interesting one. And for the affirmative, I'm delighted that my colleague, Gwenda Summers, is going to be presenting. She's the Director of Families Forward at Community Mental Health Authority for Clinton, Eaton, and Ingham counties in Michigan. And for the negative position, we have Dr. Vernon Barksdale. Dr. Barksdale is the medical director for Mind 24/7. So we're going to start by giving Gwenda 5 minutes to present her affirmative position. Go for it, Gwenda.
Hi, thank you so much. I'm so excited to be here today. Few things are more important to me than talking about families and their role in treatment. And I've been very delighted to hear that we're talking about families being involved in crisis treatment, which I think is something we need to continue to strengthen. We absolutely fundamentally need to recognize, promote, and support the value and power of family in sustainable crisis work and sustainable change after crisis. All youth have some type of family or support system. Even youth and child welfare have a support system. They have people who are helping them navigate to their next setting, to their next intervention, but all youth have some type of family support. Those attachments and family bonds are so powerful, even in situations where families are stretched and stressed and in challenging situations. Those attachments and bonds are powerful. Family is needed during a child's most vulnerable moments in crisis to help support them and comfort them and to work on those services. Imagine how frightened a child would be during their most vulnerable moments to be with strangers without their support of their family. Families also need to be there during the crisis intervention and crisis stays because family solutions work best. We are often humbled by the solutions that families come up in the midst of really chaotic crisis. Their solutions are often more simpler and always work better than ours. We come up with complex solutions and families are able to make it simpler and come up with what will work in their family because they are the expert in their child's life. Families also have a primary decision-making role in the care of their children and are the primary agents of change. Imagine what it says to a parent to say, hey, we need you here at your child's most vulnerable moment because we need your help. You're going to be the one who's going to be the most helpful to your child, and we need to support and coach you. They are the stabilizing ingredient. All of the research around kids and families indicate family as being a critical ingredient in the outcomes for kids. We do this in crisis care by seizing the moment. We seize the moment. Oh, there we go. Next slide. Thanks, Kristen. We seize the moment by recognizing that families and youth are most urgent for change during those crisis times. Those are the times that people are really ready for change and need that change. And so it is so important that the families are there to engage in that treatment. Crisis care is treatment, and we really need to get back to focusing on it being treatment and not respite or something else. Respite is an important piece of the service array, but it's not crisis intervention. That's a disposition or a service we need to put in. Administratively, using our crisis centers as respite is not sustainable or affordable, given the rates of crisis care versus respite. Crisis care is treatment, and it's family treatment. The outcomes from crisis care being treatment are much higher than when we don't involve families in that treatment. Many people may say to me, hey, families come in and they're arguing. We need to give them a break. Absolutely, respite needs to be a part of things. And also at times during the crisis care, that family therapy includes parent in one room, child in another, de-escalating, talking about how when we get back together, we'll be able to talk about things. Oftentimes our interventions bring those youth and families back together to practice skills. Sometimes that's in the form of an activity and generalizing that to outside of the crisis contact, or to talk about deep core issues. It's also important that they participate in the entirety of the plan. So we plan to carry it forward. Having parents and guardians and other support systems there the entire time gives us an organic way to make sure their voice and strategies are weaved in through every crisis moment on that crisis episode. It helps us practice and plan. We support and coach parents on new strategies, increasing their confidence. We help youth with coping skills. We help youth talk with their parent in that episode. And then we make a plan for them to take home with them and recreate that there. We can't do that without parents.
Great points. Okay. From there, we're going to turn this over now to Dr. Barksdale, who's going to speak to the negative. Don't make them stay. Dr. Barksdale, go right ahead.
You're muted.
Oh, my mic says it's working. There we go. Okay, thank you, Gwenda, for that great presentation. I want to be transparent and admit that I left my psychiatry training to take family systems therapy supervision in a community clinic. It was very important for me to understand the family system, and I wasn't getting that in my child training. And so I agree with many of the points that you're bringing up. And I wanted to say that part of the work we do in the crisis setting is to honor that process by doing a trauma-informed evaluation. And in that point, we are now going to work with the information from the parents, guardians, group home staff, as well as with the patient. However, our physical layout and the staffing shortages we have are part of the problem. Our systems are not designed to do long-term therapeutic interventions because we have a crisis environment. That means we're getting police drop-offs, we're getting mobile teams bringing folks, quite often with the family driving along in tow behind them. And those kids are in a significant amount of emotional and behavioral dysregulation. We also have this issue of the identified patient, that quite often the system works to identify the youth as the patient and puts the family in the role of not being the one needing to change as a unit, but to see this child as broken, fix them, and we'll come back and we'll pick up the pieces later. And also, they're more cost-effective and clinically appropriate options that are currently available. So let me go to the next slide and talk a little bit about our setting. One of the problems we've had, especially post-COVID, is our inability to staff our units adequately. We're not like a major hospital where we can have sitters come in and be with a family while they're waiting and going through episodes of treatment, or as our prior presenter said, having the child in one room and the parent in the other room. That's a physical layout restriction that we don't have. And we also have an issue of throughput. As we're getting more people coming in, we have to be able to redeploy our staff to manage that. If a crisis comes up in our service provision, at a police drop-off or a patient in the lobby, our team has to redeploy in order to man that need. And again, we don't provide the services for the family as they're waiting to go through more therapeutic intervention. Therapists are also needing to be trained in crisis intervention. Most of them are trained in psychotherapy. We had to really retool our therapy staff just to find the right crisis-focused therapists that can help families at that important juncture. And since opening, we found that 47% of our youth admissions get admitted to our crisis unit. So they're coming in a significant level of acuity as far as their behavior and emotions are concerned. They're being identified as the patient by law enforcement, by mobile crisis team, by parents, by CPS workers. And so as a result, we have this disconnect on what the needs of the patients are from the point of view of the family system. Let me go to the next slide. In my training in structural family therapy, we recognize that the family needs to change as a unit, that there's collaboration between relationships, that there's areas in the family that need intervention, that there's folks that need to move out from the blaming role into the family unit role. As we would say, the family gets sick together, the family has to get well together. But in that crisis episode, we're unable to move the family in that direction. So we have to move to more affordable and also available services that can make a difference. Let me go to the third slide. And so what we've learned to do is to innovate. And so we retool our whole crisis system to get good evaluation and stabilization done, and then have ready access within the next day, within 12 hours later, so that family has a chance to take a deep breath and get back into the services available to them as far as individual, family therapy, and also we decided to open a crisis IOP. So all our therapists are focused on helping that family stabilize the crisis, come together and start to move from the point of view of the identified patient to the family as a unit, and how we can get siblings in, other persons living in the home into those sessions. And we can now do it in a more thoughtful, planned out manner. So that way we're not causing a deluge of patients just being backed up into our crisis lobby, and we're not able to meet their needs because we're tired of trying to do therapy sessions. It also allows us to triage cases where we do have sometimes folks come in who just want information, or folks who come in who have a minor problem and they are open and available to a therapeutic intervention, and we can then tailor that need in our service area. But meanwhile, those other folks, we can move them into our crisis services post-crisis. And as a result, we are now able to meet their needs, and we can then get more people seen and taken care of in the situation. So it's a very cost-effective process. We found that we had less recidivism. So that means less of those patients are coming back for another crisis intervention. They're more coming down for that outpatient services, and it's going to be by appointment. We have a system to reach out to folks and to stay in contact with them, as well as get them to their service provider and community if they have an established therapist there. So what that does is that it helps that patient get the ready access that they need in that critical post-crisis episode, without them having to stay at our facility and create, a backlog in the lobby, and oftentimes not give them the services that they need, or not having the critical members of the family there at that point. It may be just one parent came in, we need the other one available. There may be particular siblings or the persons such as a CPS staff worker. We can do emergency CFTs the very next day, and again, pull those different agencies together to help formulate a better crisis plan for stabilization and that critical post-crisis period. So I believe we have the ability to make this happen successfully, being innovative and using other services in a unique way in that critical post-crisis period. Thank you.
Awesome. All right. So now we've heard from the affirmatives and the negatives. Thank you, Dr. Barksdale. So I want to ask a few follow-up questions to each of you. For Dr. Barksdale, I'd like to understand, one person in the chat said something that was on my mind and something that came up in our discussions. How are you able to care for the children if you're not a child caring institution with the parent or legal authority not present?
Well, that's a very good question, because when those drop-offs occur, most of the time the parents or the CPS worker is not there. We're empowered by the state to admit them out of the ruling that this is a vulnerable individual and we can't not discharge them to the street, and they're not capable of voluntarily leaving our facility. And so we are able to admit them and get an assessment done. Then we do our outreach to get consents for medication and start to pull those persons in who are involved in that that child's case. We have a unique program with the state sex trafficking division that allows us to work with a lot of our youth that are out on the streets, for example, who are coming in who've been missing for months at a time. So we're very comfortable with getting them in and getting assessments done and getting some of their medical needs met.
So you have some specific ways within your state that allows you to care for the child, even if the parent or legal custodial authority is not present.
Yes, as far as assessment is concerned and provision of emergency care.
Got it. All right. Now, Gwenda, turning to you, a question I have that I thought about when Dr. Barksdale was speaking about his background. How do you ensure, if you are having the parent stay, that the intervention really meets some kind of evidence base around family systems of care, since not all crisis staff would be trained in that kind of therapeutic approach?
Yeah, great question. So all of our staff are trained in a curriculum that we have been developing over 20, 30 years we call it our strength-based learning approach. And it includes family modules and how to do family treatments. We also have staff who are trained in Michigan evidence-based practices around PMTO and trauma and DBT. And so our clinicians are trained in some of those evidence-based practices. They have the crisis professional training, but the majority of our training comes from the practical curriculum that we've developed around integration of families. Most recently, we're also developing a curriculum around like milieu and what are appropriate interventions based on best practice of family treatment in the nation.
That's amazing. That's really amazing. One other question I have for you, though, Gwenda, is what about those parents who would like to stay but have other children that they have to take care of, have jobs to go to? In my experience in emergency departments, that is one of the biggest reasons that parents get stressed, because they have other things that they have to do.
Yeah, so a couple of different approaches, because of course that does come up. So first of all, we're working as quickly as we can to stabilize and get people out. We do have the ability in our crisis continuum to quickly link to service because we directly provide those as well. And we do have our crisis respite home. So some of it is quickly figuring out triaging and being able to immediately access different levels of care. And I think the doctor spoke beautifully about that as well. So the ability to link them to care drastically reduces the time that is needed. And in those situations, sometimes respite is needed. And so we're able to use our respite home. When they aren't, let's say they're waiting for a hospital bed or we're waiting for things to calm down, we try to do an individualized plan with every parent. So we've had parents who have said, you know what, I have to scoot out and get my diabetes medicine, and we're like, okay, for a couple hours, we'll have them working with the milieu specialist on X, Y, and Z. So when you get back, we'll kind of pick up where we left off. We've also had parents, I'm amazed by parents. Parents want the best. And it's like, you know what? I don't want to leave my child here. Grandma's going to come and stay with them. And so we allow some flexibility in that interaction around that. Or we work with parents to, can you take the day off? And sometimes they can. But it really is key. Yeah.
That's great. Great answers. I got to move us along. And I know you have some closing remarks that I want to give you time for. So Gwenda, why don't you start with your closing remarks, and then we'll follow that with Dr. Barksdale before we do the roundtable.
Great. So we're doing a great job in our state and nation of developing the crisis continuum. Yet we really need to further define which each of these services are and how they're going to get the best outcomes. So, I've said it, but I'll keep saying it. Crisis care in these centers is treatment focused. It's not respite. Do we need to develop respite? We absolutely do. It's a critical component in our community. But we need to have our crisis centers focused on treatment. People are there for a reason, and that's around crisis care. They are there to participate in some kind of treatment so they don't come back the next day and the following day and the following day. We also need to get back to really promoting and training. I loved your question about evidence-based practice around family training. I think that's being lost in some of our clinician training. And really, it's all about families. If you're coming to our center, you are getting some type of family treatment. We also need to stop focusing on logistics, right? There's logistics in everything. Everything that we could do could have a logistical reason why it wouldn't happen or why it couldn't happen. And so we need to bust those barriers. Sure, staffing is a crisis. It's also going to be a crisis if we have to have safety sitters 24/7 while people sit in a sort of respite sort of setting. And so logistically, we need to bust those barriers. That's why we're here, is to create interventions around that. I'd like to tell a story about a family who was in our center, who the mom, and I know I just have a few more seconds left, mom was very triggered by things going on, a lot of family conflict. People said they can't be together. Through a series of interventions of apart and back together, mom really disclosed that she had some trauma, and that trauma was impacting her ability to manage this kid. We had a therapist sit with mom and access her own care and get linked with the trauma therapist. If we don't involve families, it's not good for the youth, and it's not good for those who are caring for them and who will be caring for them, because we're not going home with them. They're not going to live in our basements. They're going to live with their families where they should be. Strengthening families is where we need to put our energy.
That's amazing. All right, Dr. Barksdale, let's hear the final word from you before we go to roundtable.
Well, the most wonderful thing about this debate is that there's so many things we hold in common that has been articulated today, and I'm very excited about that. I think one of the areas that needs to be further explored is how we build that continuum, as Gwenda was saying, because quite often we are getting respite care provided at our crisis unit because the respite programs in the communities aren't capable of accepting these kids, saying that they're too out of control, they're too dangerous and too violent. We have kids now resting in our facility because level 1 psychiatric hospitals won't take them because they're too violent. So we really have had to innovate and work on these strategies of intervention with our crisis therapists, meeting with those kids on the unit, as well as getting those families further involved in that setting. And one of the things that has happened is that we've just moved that where that service occurs to our post-crisis section versus within the crisis facility itself. I think these are two unique ways of approaching it. I think the physical layout would have to be different in order for that to occur. And also because we're labeled as a crisis drop-off unit, where we're getting those police and mobile crisis team, fire department bringing folks in, emergency room sending us folks, our mission does require us to accommodate those patients in a safe, appropriate setting, which doesn't allow us to have the family therapy work occur as robustly. Let me talk about that other 43%, though, that I said didn't get admitted. Those were the ones that came in a crisis. And what has happened is that they've been able to avail themselves of our IOP, intensive outpatient program, family therapy starting the next day. Sometimes we'll do a discharge family therapy session. So they are getting some of that work right there because they have, by triage and by their own stability when they came in, allow themselves to be available for that type of work and intervention.
That's great.
We're all done? Okay.
That's great. Yes, that is awesome. Great last words. And honestly, I think what you're both saying, very similar themes.
Yeah.
Where you draw the line, the continuum really matters, making sure that there's other services available for families. And with that, I think I'll turn it back to Laura, who will host the roundtable.
Thank you, Deb. Thank you, Gwenda. And thank you, Dr. Barksdale. Again, very fascinating discussion. Our chat, I don't know if you all have seen it, is lit up. But before I go into the chat, let me bring in our roundtable participants. So we have Jim Westcott, who's the COO, Chief Operating Officer of Mind 24/7. And let me go to you. And also Krista Hauserman, who is with the Michigan Department of Health and Human Services. Jim, let me go to you first and get your thoughts on the debate, maybe the chat, and kind of what comes to your mind as you were listening.
Thank you, Laura. Hi, everybody. Thanks for having me on. And thank you, Dr. Barksdale and Gwenda, for a great debate. I think you both raised really strong points on both sides. Well, at the end of the day, ultimately, we know that we have to do what's right for the child in our care. And oftentimes that does present unique challenges for us, right, as leaders in healthcare. And how do we enforce a family to stay if they're not not required to stay, right? And then there's those unique challenges of, as you know, Gwenda highlighted, what happens when Deb brought up, what happens when there's a single mom who's there and, you know, we have a child in crisis, but she has other children at home that are in school that she's got to get off the bus. And so, you know, it puts us in a really difficult position, obviously at the core of recovery here, and support for these children is that family unit and supporting them through the crisis. So I think it was a great debate. I think what was highlighted for me, a great takeaway, is ensuring that crisis continuum and closing the gaps of care that exist, and learning from everyone else locally and nationally about the great work that's happening. I think it's fantastic to be able to triage appropriately, you know, patients to respite, or and some ability to be able to decrease hospitalizations, unnecessary hospitalizations, that is, and instead of that old dumping ground, okay, what do you do? And we're just going to put them in here at home because we don't know what else to do with them. So I'm really proud of the work that I see happening in this organization and across the country. And I'm just really, I'm inspired by this conversation this morning.
Thank you, Jim. Appreciate that. I think that is a rhetoric that we can all get behind. Just so much good information, so many good perspectives. Krista, would you share your thoughts with us?
Absolutely. Hi, I'm Krista Hauserman. I'm from Michigan, and I applaud the innovation and commitment of both our debaters. I will tell you, I've been in the mental health field, especially serving families with children with mental health issues for a very long time. And this is such an exciting time for all of us in crisis services. I also will tell you, since I've been in the system a long time, I remember when there were no home-based services. I remember when respite was not a thing. It wasn't out there. There was no term. It just didn't exist. And so I encourage us in this time of change that as we build these services, that we really step up and we look at the things that work and we build them in a way, we do it the right way, and we push ourselves to do it the right way. And I think that we do know that family involvement is very important. When you're looking at the documentation out there, we see that family involvement brings sustainable change. And so let's build physical environments that allow families to stay, so we can encourage families to stay so that they can be part of the solution. Another thing that I've learned during my career is that I get the best advice from listening to the people that we're serving. Right now in Michigan, we are interviewing families with lived experience, and those initial results that are coming back, the message is pretty clear. They say, yes, you can take my child someplace else. Like, my child struggles, they go someplace else. And yes, you stabilize my child in that setting. But when they come home, I'm the one that needs the skills and the tools to support them. The child needs to be stable in my home. The child needs to be stable. My child needs to be stable in school. So I want to be more involved. And they really are asking for a strong continuum of services. I'm glad that's brought up. And if there's one thing we walk away with, it's one crisis service isn't going to meet everyone's need. So we really do need to wrap around families and support them and have a whole continuum of services. And I challenge us also to get better at working with families. I'm a therapist. And I don't practice anymore, but I'll tell you, it was a lot easier working with one person than working with the whole family. Can be more challenging, especially when you have them in the room, all those dynamics. So let's get better at that, because we know that family does have an impact on the physical health care side. When you go to an emergency department, families get to be there. Families provide a much more holistic perspective of what's going on in the situation. You don't have just one person's viewpoint, you have that whole picture. So let's find a way to strengthen their involvement and maximize the impact that they can bring, and challenge ourselves to do it. Let's not say, hey, we don't know how to do this yet, or we don't have physical buildings. Let's say we know this is the right path and let's do it. Thank you.
Well said, Krista. Thank you so much for that insight. And I think I hear just lots of threads, right? Of, sometimes, as mentioned in the chat, that parents and families can be part of the problem. But to your point, they're also part of the solution, particularly for youth and young people. And I think Dr. Barksdale, you also said something around family systems and that training. So even taking it further upstream to making sure that our clinicians do have that training to take a look at the whole systems. Thank you all so much for this discussion, this debate. This has been very eye-opening for me, very helpful to see various perspectives and challenges and ways that folks have seen it play out in their careers. Thank you, and thank you to Deb for moderating. Again, just did a phenomenal job with that. So I think we are going to have our post-debate survey, and click here to see, now that you've heard the debate, both sides, do you think that crisis facilities should require parents to stay during a crisis episode? And we will reveal the results in next week's Jam. So vote now, but stay with us so that you can see how persuasive it was. And again, there are only winners of the debate because it just helps us further our knowledge. I'm going to now turn it over to Christy Malik with NASHBID for a state update.
Great. Thanks, Laura, and thank you for that warm introduction. And great to see you hosting today's Crisis Jam. So for this week's NASHBID update, I just want to highlight that NASHBID and Vibrant Emotional Health will be co-hosting a webinar on June the 26th, which is next Thursday from 2 to 3 p.m. The webinar is focused on 988 liability protection. So next slide, please. Great. So Vibrant will be providing an overview of 988 and 9111 liability protection across, just an environmental scan of what's happening. Next, we will hear from a contact center in Nebraska and also in North Dakota, and they will discuss their efforts and lessons learned in securing 988 liability legislation for their 988 counselors when the 988 counselors are acting in good faith. So we hope you can join this webinar opportunity. My colleague has posted the webinar registration link. Please register. We know this is a busy, summer vacation travel time, but if you register, then the recording of the webinar and supplemental materials will be sent to you. So, and again, thanks again for a great discussion on today's debate. And Laura, I'll turn it back over to you.
Thank you, Christy. Appreciate the work that NASHBID does. Very excited for that webinar. Make sure you sign up. And again, thank you to SAMHSA, who makes funding available for those webinars. So let me transition it over to Stephanie Pasternak with NAMI and Daniel Heron with Vibrant Emotional Health for an update on states and funding and how everything's going.
Yeah, thanks, Laura. So I'm happy to jump in. A lot is happening at the moment. So I will actually start with Illinois, which you'll notice is now in the gold color. And that's because Governor Pritzker, when he signed Illinois' budget into law earlier this week, it included a 988 fee. So that the Illinois fee is not really a set amount. They took a slightly different approach where they've taken an existing telecommunications tax, raised it from 7% to 8.65%, and that revenue that comes from that increase is to go to 988. And it is expected to raise $49 million a year. And that also puts us up to 12 fee states now. So shout out to everyone in Illinois that supported this, and also a special thank you to Representative Lindsay LaPointe, who, from my understanding with talking with advocates there, did a lot of the heavy lifting in seeing this fee happen. And then I'm going to jump over to Nevada. This is not a funding bill, but awareness that AB 380 was enacted. To explain what this is, this revises state requirements on the composition of mobile crisis teams. So right now, at least, one behavioral health professional is required, and generally the desire has been to have a peer support specialist on that team as well. But that has proven to be a real challenge given the workforce shortages there. So what AB 380 does is expands the list of professionals who could be that second member of the team. Of course, folks still really want to see peer support services grow, but supporters felt this added flexibility was necessary to make sure that mobile crisis can be present in more communities. And then finally, I will also talk about New Hampshire, and this is something that is happening right now. The New Hampshire legislature is finalizing their budget, and interestingly, a 988 fee is hanging in the balance. So the budget is sitting in a conference committee. So that's a group of House and Senate legislators who are charged with creating the final version of the budget. The Senate language had the fee, the House language did not. And as it stands now, the House version of the language is winning. So I will post something in the chat where if you are in New Hampshire or folks who are Granite Staters, today and tomorrow, you should definitely reach out to the House members on that committee and let them know that you want to see a 988 funding in the final package. Advocates have worked very hard to get this far, so any support you can provide is very appreciated. And with that, I will turn things over to Daniel.
Great. Thank you, Steph, for those updates. Just a couple more to highlight. Want to start with the U.S. Virgin Islands. While not a state, they're a U.S. territory. And I don't believe that we've highlighted on the Jam before, but back in 2024, they did pass a 988 telecom fee at $1 a month, which is to date the highest amount for a fee. The U.S. Virgin Islands doesn't currently have a 988 active contact center, but they are building the infrastructure to support the crisis continuum system in that territory. So great news in USVI. Also want to highlight in Wisconsin, there's a couple of bills that we're watching. The first is SB 309, which is one of those liability protection bills, specifically for public safety answering points and dispatchers when they're transferring calls to 988 and transferring 988 callers. Of course, it protects them from civil liability when they're acting in good faith. Another shout out for that NASHBID Vibrant webinar that will talk more about that. In Wisconsin, there's also a bill that would expand the grants that the Department of Health Services offers for crisis intervention services and crisis care coordination. That bill just passed its first Senate committee on Monday. And then finally, I would just mention, we may have mentioned in the past, but we had previously mentioned the Alaska fee bill. Unfortunately, the session ended before that bill could make it through, but it did reach the third committee, and on the last day of the session, a companion bill was introduced in the Senate. So it looks like in Alaska they'll have some momentum heading into the next session, but did want to give that update as well. And with that, I will turn it back to Laura.
Thank you, Stephanie and Daniel. Appreciate all that you all do to keep us updated on what's happening across the country at the state level. A lot of things to track and just appreciate those updates. Okay, so now I will turn it over to, I believe, are we turning it over to Stephanie Hepburn today?
Yes. Hi, Laura. Thank you.
Hi.
I'm going to welcome on Dr. Nancy Byatt. She launched MCPAP for Moms, which is a real-time psychiatric consultation line for providers serving pregnant and postpartum women. Dr. Bayat, can you tell me the gaps that you were seeing when it comes to perinatal mental health?
Yeah, absolutely. It's a pleasure to be here and be with these really important conversations. So we know, and we have this on the slide here, that mental health and substance use disorders, they're common. They occur in 1 in 5 individuals. They are also undertreated. So for depression specifically, even if a woman screens positive for depression, less than a quarter of them will get even to an initial mental health appointment. And there's many gaps, which we don't have time to go into, but there's many gaps at the patient level, the provider level, and the systems level. So when I first started doing this work, I was a perinatal psychiatrist seeing patients at an OB clinic, and patients were presenting to me, reporting all these symptoms. The OBs were saying, we don't know what to do, and we don't know how to respond. We want to help. It was taking forever for the patients to get in to see me. And a few things struck me. One was that there was an unleveraged opportunity to address mental health in perinatal care settings, pediatric and obstetric settings. The other thing was the profound impact this was having on the parents and their babies when it wasn't getting addressed. And then the third thing was that nobody was talking about it. There was this unleveraged opportunity between the providers and the patients that where this could be addressed. And the last thing is that there was no psychiatrist and mental health clinicians to be able, not enough to be able to see them. So that was what led to sort of us developing MCPAP for Moms, the Massachusetts Child Psychiatry Access Program for moms, built off the MCPAP model for kids.
And then if you could give a couple of examples, one thing that I thought was really, one of the quotes that I thought was really interesting when you were doing your focus groups was that, screenings just on their own are simply not enough. And one of the individuals shared with you that after the screening, she'd been told, well, by the person who conducted the screening, you have a healthy, happy baby, what's your issue?
Right.
And I thought your response was so great because you were like, this is somebody who cares about their patients. This is just a lack of education.
Right.
And bridging the gap helps to not only give somebody that lifeline like you talked about, but it also helps to elevate people's knowledge about mental health generally. Can you talk a little bit about that?
Yes, absolutely. So exactly. The quote was the patient was screened and they said, you have a happy, healthy baby. What else do you want? And that's not, again, because like what we found is that the nurses and all the individuals working with these patients really wanted to help. They did not know how. And the OBs actually said, we asked them, are you suicidal, homicidal? And we hope they say no, because if they say yes, we don't know what to do. We don't know what to say. And so that was one of the major things that we were seeing during that time, and a couple of the examples. And they really, really wanted to help. So what they told us when we asked them, well, how could we help? And we asked them, what would it be like if you could call and speak with a psychiatrist? And they said, that would be a lifeline for us. That's actually where we got our center is called Lifeline for Families, because they didn't know and they needed that capacity building, and there'll never be enough psychiatrists to see the individuals that need one. And so MCPAP for Moms, our statewide program, which has now become a national model, there's now 30 programs modeled off of it, including MCPAP for Moms across the country, really is there to build their capacity, leverage psychiatry and other mental health professionals as a limited resource, and build the capacity to integrate this into mental health care. So to give an example, if somebody has high blood pressure, they would be screened, it would be followed up, and they would make sure the blood pressure is under control, right? With depression, what we see in primary care settings and anxiety, it's often, oh, well, you screened positive. Let me know if you need anything. Or like, you've screened positive, start a med and say, let me know if you're still depressed. Like, we would never do that with blood pressure. We wouldn't say, let me know if your blood pressure's high. Or like, we would really follow it up. So the goal is to sort of have, mental health and substance use disorder care part of the workflow, just like any other medical problem.
And it sounds like also like the clinical recommendations have also gone in line with what you all are doing with the psychiatric consultation line. Do you think that has also helped shift culture, for example, for obstetrics?
Yes, I do believe that. And I'll give some examples. So when we first started, really people were saying, this was in 2012, we started MCPAP for Moms in 2014. And what we were hearing from people is that people literally said, OBs are never going to do this. They're never going to prescribe antidepressants. And we had a couple quotes in our focus group was, I was trained to take care of a uterus and the ovaries, and I was not trained to take care of psychiatry. What we've seen happen is, one, having the resources helps shift the culture. We're amazed now that we get calls from obstetric clinicians. They're calling and saying, well, I've tried a med, now I want to do something else, or I know the patient needs therapy, and they're calling with really sophisticated questions. So when there is a lifeline for them and their support, they're willing to change their practice. The other thing is that back in 2014, when we started ACOG, there were no recommendations, professional recommendations for screening. Now, ACOG and AIM, which is the Alliance for Innovation in Maternal Health, ACOG, the American College of OBGYN, they both, and many other professional organizations, recommend screening. And ACOG and AIM specifically recommend that it's, like I was talking about for high blood pressure, that it's screened, addressed, treated, and followed up for both mental health and substance use disorders. So that has absolutely made a difference. It shifted the culture. I would say it's a combination of mental health awareness increasing. The junior clinicians are far more receptive to this. The second piece is the recommendations and it being endorsed by the professional societies make a huge difference. And third is that, along with resources to help them and these capacity building services and tools, I think it's a combination of that has really shifted the culture, where it's really seen that mental health needs, that is the recommended standard of care, that it's dressed a part of perinatal care.
Thank you so much for joining me, Dr. Byatt, and I'll pass it back to you, Laura.
Yeah, thank you. Pleasure to be here.
Thank you, Stephanie. Thank you, Dr. Byatt. Such great conversation, very much needed. And I also want to shout out Massachusetts and the work that you all have done around maternal mental health through the work of Representative Jamie Belcito and others. There was the creation of a national mental health line called 1-800-TLC-MAMA. So folks can use that if they're experiencing any kind of distress related to, being postpartum or being a mother. And of course, the 988 Lifeline is available at 988 for anyone. So thank you. This is a very important conversation for us today. Let's move forward to see what's coming up next. So next week, we will get the result of our debate, but also it will feature North Carolina's 988 and peer warn line integration. So we'll have some folks there who will be sharing how North Carolina is doing it. And again, happy to learn from every state. This is why we're here. And make sure you take what works for you, tweak it, and kind of showcase it in your state or community. And then after that, we will have a fireside chat. So in 2 weeks, we will have a fireside chat with the grandfather of 988 and crisis care. I'm not sure if he'll like me saying that, Dr. Richard McKeon, who has just been such a pillar of crisis care, has overseen the 988 Lifeline, and when it was known as the National Suicide Prevention Lifeline. Very excited. Please join us for that chat. That is going to be wonderful. I'm glad we've got permission to call him the grandfather. I think that is it. Thank you all for joining us so much. Appreciate you hanging in with us for this hour. It is a wrap. Hope you enjoyed the debate and have a great day.